Hi everyone. Thanks everyone for joining the panel and the audience. Hopefully you can hear us well. So I'm Dan Roth. I've been asked to guide this distinguished panel. So let's start. We'll start with a brief introduction by everyone, and then we'll move on to some of the questions that will start this panel. So as I said, my name is Dan Roth. I'm currently the Chief AI Scientist at Oracle, leading the Gen AI science activities. Oracle is making today a big effort in Gen AI, both as a hyperscaler and on the technology side, developing the technology and services that support Oracle internally, databases, SaaS, health, and more, and our customers. I'm just celebrating my first year at Oracle this week. Before that, I spent about 3 years at AWS at about the same role, leading the science of Gen AI, including services such as Amazon Bedrock, Amazon Q, etc. And along with that, I'm also a professor at Penn, so I've been in academia all my life. It's all my career, about 25 plus years now. And finally, I've also been involved, I'm still involved in multiple startups in the machine learning, NLP, and Gen AI space, including healthcare domain. So with that, let's move to the others. Let's start with Duncan.
Dan, thanks for the wonderful introduction. I'm so excited to be here. I'm Duncan Eddy, a current research fellow in the Stanford Center for AI Safety, as well as the Human Center for Artificial Intelligence, two different institutes that focus on cutting edge research in terms of AI systems and how they can affect and improve life and society for everyone on this planet. Prior to this, I was at AWS for a number of years, as well as working as an applied scientist in the distributed systems group, so building software services for the space industry. Before that, I actually worked on a number of different startups in space operations. So we were building automated systems to control satellite operations, applying decision-making systems to safety-critical applications, as well as, and eventually leading the space safety group for Amazon's Project Kuiper. Since then, I've been doing a bunch of different research projects on applying AI and AI decision-making systems, from everything from autonomous trucking to building safer LLMs through automated red teaming. So that's myself.
Thank you. Let's move on to Maneesh.
Yeah, Dan, thank you. It's a pleasure to be on. Maneesh Goyal. I'm the Chief Operating Officer for Mayo Clinical Platform. My career maybe summarizes into taking unstructured ideas and building them to something of societal value. Helped to start and build a semiconductor company, Broadcom Corporation, a Fortune 50 company today. Then hopped over into venture capital, where I really learned the art of equity-based investments and healthcare technology. Spent 7 years doing that. Jumped back into an operating role where I helped to build a health tech company focused on patient engagement, sold that, and then helped to write the business plan that is Mayo Clinic Platform, and been in the operating role here for 5 years. And we're primarily focused on the notion that, you know, if you come to one of our sites, one of Mayo's sites, you'll get high quality care. Mayo's been rated as one of the best hospital systems in the world for multiple years. And the question is, what do we do with the billions of people that can't get to one of our high quality institutions? And with the advent of high throughput computing, highly available data sets, I think we can start to solve some of the diagnostics issues that result from lack of high quality personnel and resources. So our goal, very simply put, is to impact billions of lives through the knowledge that exists in Mayo's data repository.
Yeah, thanks, Manish. Gagan, and please pardon me if I don't pronounce the names correctly. Please correct it if needed.
Yeah, thank you so much, Dan. Yeah, I'm Gagan Bansal. I'm a researcher at Microsoft Research, the Air Frontier Lab in Melbourne. And I've been about Microsoft for about 3.5 as a researcher, and prior to that, I was a grad student at UW. And throughout my research career, I've been very enthusiastic about understanding and improving interaction between people and AI systems. So a couple of years ago, in grad school, I was looking at interaction between people and classifiers and trying to think about how do you get classifiers to really augment people, make using them as assistants. Moved to Microsoft, we really started thinking about GitHub Copilot and trying to look at interaction between programmers and GitHub Copilot. How do you unpack that really complex interaction and improve it? More recently got interested in agents and trying to look at human agent interaction. I've helped create several popular open source projects at Microsoft, like Autogen, if you've heard about it. We've created state-of-the-art agent teams like Magentic One. We've created human-centered web agents like Magentic UI that we just released. And so I think to sum up, my research is really about trying to bridge the HCI perspectives and the AI perspectives and trying to really put the users at the center of development of these technologies. And I'm very curious to learn about the healthcare sort of perspectives from the experts in this panel.
Yeah, thanks, Gagan. Let's move to Anil.
Yeah, hi everyone, and thank you, Dan. I'm Anil Jain. I'm the Chief Innovation Officer at Innovaccer. At Innovaccer, we are a big data analytics company bringing all the different disparate data from a community of care together into a common platform. And most recently, over the last 18 months, we've been working on AI copilots as well as AI agents to help support some of the broader needs that our community of health systems, provider organizations, and health plans need. Just a couple of weeks ago, we just announced Gravity, our AI, essentially an AI orchestration platform that helps connect some of the work that we've done on data for health systems with some of the accelerants one would need from an ML AI point of view to help promote the responsible use of AI, but also sort of taking like the 80-20 rule, so let the AI developers focus on the use cases rather than the data cleanup and the data mapping and all the privacy and security required by health systems for this. Prior to Innovaccer, I spent a good amount of time at Watson Health, where I was the Chief Health Information Officer. And prior to that, became an IBMer overnight through an acquisition of a company I co-founded called Explorus, that I basically had spun out of the Cleveland Clinic, where I was an internal medicine doc, a clinical informaticist, and IT leader. And I too am looking forward to the conversation, and it will be a very lively conversation given all the topics that we're going to be talking about. So thank you.
Yeah, thanks, Anil. And last but not least, Soroush.
Thank you, Dan. So my name is Soroush Saghafian. I'm a professor here at Harvard. I teach a course on machine learning and big data analytics, again at Harvard. And I've been affiliated with Mayo Clinic, I'm right now affiliated with Mass General Hospital, with some other hospitals, including Beth Israel. And I have a lab, so I'm a founder and director of a lab at Harvard. It's called Public Impact Analytics Science Lab. So we have lots of projects with health organizations and other organizations on essentially using AI and machine learning tools on impacting healthcare organizations. And so I'm looking forward to the panel today and to learning from what everybody thinks.
Okay, thanks everyone. Really excited to be part of this. And let's move on. So each one of us was presented with a question, and we'll spend a little bit more maybe discussing these questions, and then some discussion following it. So I'll ask each one of you to read the question when that you were posed, or some rephrasing of it that you want to address. And I'm going to start with the question that I will kind of address. So the question says, given your extensive work in natural language understanding, reasoning, and machine learning, how should we rethink the design or training of large language models to improve the reasoning capabilities and reduce hallucinations, particularly in high-stake healthcare settings where patient safety is paramount? So I'd like to address this from a slightly more general angle, because I think it's really not about design or training, and there is really no real way to improve reasoning capabilities of base LLMs. So the panel is titled Hallucinations, Harm, and Hype. And I'll try to address it and this question by making 3 points. And the first one, yes, there is a lot of hype and models will hallucinate, and it can cause harm. So I think what has happened in this space is that model providers would like to convince us that LLM will solve all the world's problems. And there is a lot of excitement from user side, since this is really an exciting technology that can do a lot of things, and has a chance and the risk of making us more productive. But mostly the reason for the excitement from my perspective is that models really know a lot. Models can generate linguistically coherent text around what they know. And we as people that know very, very little, we are very impressed. And just to bring this point home, I don't know if you guys thought about it, all models were trained today on trillions of tokens. One book, 200-page book, is about 100K tokens. So 1 trillion tokens is about 10 million books. How many books have you read or will have read in your lifetime? If you're an avid reader, maybe 3,000. And that's why we are so impressed, because models know a lot and can access it well. This is the magic. And the surprise of this technology, in fact, something that surprised a lot of people in this area, is that once you train a model, even with a simplistic way we do, on this huge amount of data, the models can generate linguistically coherent text. And this is actually sufficient for many applications. It's sufficient to make us all excitement, because we can generate text. The model can help us write down a paragraph around our thoughts, but, and this is my second point, that this excitement, which is justified, also hides the fact that there is a really large gap between what models can do on their own and the level that we need, or corporation needs, or healthcare providers need as solutions. Because we need solutions that are consistent and reliable. And this is especially true when we want to support decision making. And the reason for this gap, or the key reason for this gap, is that models cannot reason consistently and reliably, and I would argue will never be able to do it. There's fundamental limitations on this. And again, there's a lot of confusion here too with models like R1, O1, O3 that were trained to reason in very specific situations and can do well in this specific situation or slightly around them. But at the same time, the literature shows a lot of confusion between memorization and reasoning. Models can do really well on things that they have been trained on, or things that are not too far from it. But once you move far enough or perturb the input enough, they fail and will hallucinate answers. And there are many, many examples that I'm sure many of you have seen, from Math Olympiads problems to Linda problems, to computational issues, and so on. And that brings me to my third point, which is we have to augment the models. We cannot rely on the base LLMs. And in some sense, the agentic trend that has emerged over the last year is an admission of model providers and the community as a whole that models will not solve all the world's problems, and we need to specialize them. And this will allow us, and this is a necessary condition for us to deal with harm and hallucination. We need to add components on top of the models, components that provide guardrails, components that are capable of task-specific reasonings, be it computation, planning, understanding business logic, and so on. So can we make the models more reliable and safe? Yes and no. It will depend on components that are outside the best models, and it will depend on our willingness and ability to build on what's good about LLMs. Basically a very, very good UX to build these additional components to support real decision support, planning, computation, and guardrails. So with that, unless there are any questions, I'd like to move on. I see that Duncan is happy, so let's move to Duncan.
No, I thought that that was a fantastic summary of the state of the art and a pretty good segue into my question, which is, so the question that I was posed with was, drawing from your work at the Center for AI Safety, what frameworks or principles do you believe are most effective at investigating and mitigating failure modes of LLMs for clinical report systems? And I think Dan really hit the nail on the head with the need to build systems around LLMs to provide that safety. That as much as model providers might say, at least my 2 cents is that there are going to be some inherent failure modes to this technology and systems, but that doesn't mean that it can't be useful for solving problems that are of meaningful impact to society. And what we really need to focus on is building multiple systems of fail-safes around LLM technology to enable it to be incorporated slowly but incrementally to solve problems that are both difficult but also have meaningful impact and improvement. There's no one silver bullet. There will be incremental progress made by model developers, but there are still inherent failures. I actually did a test in the 5 minutes before this call asking a model to subtract 2 numbers, 8.11 from 8.8, and it was very confidently incorrect in that. And that is with lots and lots of work over years and years, and it still can't subtract 2 numbers. You can ask models to tell time, and they will still get that wrong immediately, pretty much to this day. Nearly every time is 10 and 2, just because that's how watchmakers like to pose their watches. And so while these systems have what we would almost think is comical failure modes, that still doesn't mean that they can't provide benefit to society as well, and incremental progress. And so we can draw on not just the frameworks and the safeguards for building reliable medical technology, but there's lots of work across different aspects of society, from aviation and air transport, as well in power regulation, nuclear safety, lots of systems where people have taken inherently unsafe technology, but built it into reliable technology and useful tools that can help and improve society. We have some of those safeguards in place today, and we know how to do some things, from just statistical evaluation of AI models, train, test, evaluation sets. Explainability methods can help, but they aren't a one-size-fits-all solution either. We've seen many, many times that explainability methods can often give you a great and wonderful sounding explanation that is, again, confidently incorrect. There's red teaming and adversarial training that can actively try to cause a model to fail, that can teach you a lot about how these systems fail. And that's an area that I do a bunch of work on myself. And then finally, you can start to apply formal methods, which provide mathematical proofs of correctness. These are incredibly powerful and have been used to validate, again, safety critical applications, but applying that to LLMs is probably out of the reach of what the technology can do. But can we cobble together these different safety validation techniques to build a comprehensive framework that can allow us to test and validate those models? And I think even if we stopped LLM progress today, we would have a lifetime of being able to actually improve the medical industry and the medical system using the technology that we have, but figuring out where it is appropriate to incorporate LLMs as well as general AI tools, but then also mitigate their failures in an incremental way. So I'll stop there and turn it over to the next panelist.
Yeah, thanks a lot, Duncan. And just to repeat a couple of things you said, you talked about evaluation and explainability. And these, to me, are 2 key issues that as a community and practitioners, we have to address in a much, much better way. And of course, there are many limitations that come along the fact that there are limitations in models, but these are crucially important, especially if we think about healthcare. So we hopefully will have time to discuss this a little bit more later, but let's move now to Maneesh.
Thank you, Dan. So my question is around, with your background in scaling global centers of excellence, how can health systems build the operational foundations needed to responsibly implement LLMs, including governance, talent, and cross-functional collaboration? So it's important for me to go back in time to answer that question. 6 years ago, Mayo Clinic did some things that I think were seminal and set us on the right track. One, we moved into a single instance of, that was more 10 years ago, a single instance of an EHR. 6 years ago, we moved to consolidate all of our clinical data into the cloud. Back when people were still arguing about BAAs with cloud vendors, we were migrating what is today 50 petabytes of data into the cloud next to a hyperscaler, which becomes important. 4 years ago, we worked to develop a methodology to de-identify under an expert cert model all of our data. So that means structured EHR data, unstructured clinical notes, images, omics, waveforms, lab reports, etc. And again, these are foundations that are necessary if you're going to do something novel with clinical data. And then that expert cert de-identification process was not sufficient because the problem is that given enough third-party data, you can re-identify any data set, even before large language models came along. So we developed an infrastructure and a set of rules that said we will no longer allow exfiltration of data, nor bringing in new data sets into the development environment. That renders that DID data very safe, nearly perfectly safe from re-identification. Every single patient that is in our de-identified data repository is consented, so they consent into to this model. Today, that represents a little over 7 million patients from across the United States and the world, and it represents all of those different data modalities that I mentioned. That's the bedrock, right? So now we can start to do some pretty novel things. 3 years ago, we were doing predictive AI. Before that, we were doing interesting analytics. That has changed our practice. I'll give a couple of examples of that. 3 years ago, we started to do a lot of predictive AI. Today, over 300 predictive algorithms are operating inside of our clinical practice, helping to guide our physicians for better decision making. Things that run along the lines of asymptomatic diagnosis, because there's so much data on patients today that the human brain can no longer capture all of that and summarize that and make a diagnosis relative to a machine. But you need a human to interpret a machine's output. So our approach is, let's make sure our tools provide our clinicians and administrators the best reasoning possible. So that foundation, that underlying data was necessary. But we recognized that if we unleashed this, that we would need a framework to assess bias, fit for purpose, etc. So 3 years ago, we partnered with Duke and a Stanford, actually, to create the Coalition for Health AI, which established a blueprint for how you communicate bias when it comes to solutions or algorithms for clinical use cases. And today, that organization has over 5,000 registrants that are signed up for it. The next thing we did was to say, great, if we do this, how do we encourage innovation if our goal is to impact billions of lives? We made this data under the strict constraints available to innovators across the world. Today, there are over 200 companies that are using the platform for developing algorithms for early cardiovascular risk or precision medicine or new care models. But we also recognized that if we continue to do that, that would be great for Mayo patients. How do we make it broadly applicable? So we went around the world and partnered with some of the top institutions today, representing 40% of the top 10 institutions by U.S. News and World Report, with the #1 systems in Canada, South America, Israel, Singapore, South Korea, 3 countries in Africa, to sign into a data collaborative. So when you're training, you're now training on a geographically wide data set. And that helps to remove the underlying bias of any institution's data. And the last part's the magic, which is how do you make this available to all those systems that are not the Mayos or the Stanfords, or the other systems that have resources. And so we brought distribution capabilities that is EHR agnostic to our ecosystem. So today, 61 health systems are signed on, representing about 40 million lives. So all of those are necessary foundational steps if you're going to establish a global collaborative and make societal impact. Then you can start talking about hallucination and the value of AI in clinical workflow. Because until you get the blocking and tackling, and I'm sure Anil will talk about this because they do some phenomenal work around all the piping that's necessary. Anything that you do in AI is purely a research endeavor until you can do all of that blocking and tackling. So I'll stop there, but hopefully that's helpful.
Yeah, thanks a lot, Maneesh. And that's a good segue to Anil.
Sure. So the question I was given was, given your experience shaping national health IT policy, and I would also say being a victim of national health IT policy, but put that aside for a moment, and contributing to the Federal Health IT Advisory Committee. This was the committee that was set up by 21st Century Cures Act. I was one of the congressional appointees on it. What regulatory or policy frameworks do you believe are most urgent to ensure LLMs in healthcare protect patient safety without stifling innovation? And I think it's a very important question. We know, based on what has just been shared, Dan, Duncan, Maneesh, what you have all shared about the challenge that it's going to be for U.S. policymakers, regulators, and industry leaders when it comes to how do we take the opportunity that we all have and try to stifle some of the unintended consequences. We know, I think all of us would agree, that these AI-driven tools, they have the potential to revolutionize patient care. And I'm an internal medicine doc by background. It's often said that internal medicine doctors would have to read for 27 hours a day in order to stay on top of the literature. But obviously, that's not possible. So this is very, very important to anyone who's practicing in a knowledge field. It's important because it can enhance diagnostic accuracy, it can help personalize treatment recommendations, and most importantly, when we see the burnout that physicians are undergoing, and not just at the community hospitals, but even at places like the Cleveland Clinic and Mayo Clinic, there is a large amount of burnout happening from the administrative side of things. This has potential for reducing that administrative burden and even the cognitive burden. Now, on the flip side, there are profound risks. There's going to be errors in medical advice, perpetuation of bias. We already talked a little bit about the hallucinations, and the 6 of us might be able to recognize when there's potential for bias, but imagine the end users, those who are delivering care, or those patients who might be receiving these things. The ability to ensure that we are creating a culture of patient privacy and trust. And the existing frameworks out there, like the FDA's software as a medical device, SAMD, we know is insufficient. It wasn't designed to be dynamic. Certainly not. It didn't take into consideration some of the continuous learning that happens in LLMs and how they adapt and evolve. Just ask a question today and ask it 5 minutes later, and you'll see some of the challenges that we all have. And Maneesh kind of alluded to CHAI, but we know that Coalition for Health AI and the American Medical Association, they're trying to fill in some of the gaps in the various programs that they have in place. And they're doing some really good work, and encourage all of you to see what they're up to in terms of trying to provide a framework to the regulators. We also know that in this administration, there's some work being done to limit some of the states from enacting AI policy, and perhaps in this administration there might be some AI policy, but it's still early to know. So let me sort of suggest a couple things, actually 4 things, and I'll be very brief. I think we have to move beyond what we have traditionally seen in the field around medical devices, which is a static one-size-fits-all regulatory model. We need something that we would be music to all our ears, something that's a little bit more agile, something that's risk-based. So I, as a clinician, for example, if I'm using a large language model to give me some summarization of the EMR that Maneesh has exposed to me, I certainly don't need the same risk profile that I might need if I was in the ICU or the intensive care unit taking care of a patient, and now I'm getting a treatment recommendation on someone who might be in septic shock. We all recognize those two are very different situations. So we need a different risk profile. The other aspect of this would be to make sure, and I applaud what Maneesh is doing at Mayo Platform, is that you need to have real world evidence generation. We need to take the data exhaust that happens when we use these models and go back and continuously refine and measure what's working, what's not working. Use tooling to look for bias that might creep in, both implicit, and we know this from generation of healthcare models, that there is also explicit bias that often would favor lower cost treatments over treatments that might be more life saving. And we need to make sure we understand that the real world evidence generation from the use of large language models is going to be a cornerstone for how we avoid any any kind of regulation that might stifle innovation. We need robust post-marketing surveillance. That's the bottom line if we're going to move quickly in terms of the opportunities that we all have. The third thing is transparency and explainability standards. I know folks like Chai are working very hard on this to create help industry leaders like Innovaccer and others create model cards so that when folks are procuring AI solutions, they're able to look at this like they would if they were buying a box of breakfast cereal and looking at the nutrition labels. There has to be transparency. And when we are putting these different tools in place, clinicians need to understand in an explainable way why these recommendations are being made, what was the data that was being used to train these models, and what are the places where those models should not be used. I go back to the example given earlier. Why should a clinician be asking a large language model what time of day it is? It wasn't made for that. And therefore, we should make sure that those examples do not happen. Or to do arithmetic, the right tool in the right setting is going to be critical. And the final one for innovators, like all of us, is to make sure that there is room within the regulatory policy for rapid innovation. The ability to have regulatory sandboxes and safe harbors so that folks like Innovaccer, folks like Mayo Platform and others can start to innovate around large language models, create applications, maybe even do pilot studies under the appropriate institutional review boards so that we can experiment and iterate like we do in clinical medicine, like we do in basic science, and be with full disclosure with patients, making sure that they understand that they are part of these pilots, they are part of these experiments. And I think if we do these four things in a precise way, in a precise regulatory way, we can sort of create those guardrails so that we can all be assured that there is transparency around this from a patient safety point of view, but we also can continue to innovate because folks, I mean, we know this, but things are moving very, very quickly. And the opportunity is huge. There's a massive burnout rate occurring with physicians and nurses. Our population is getting more sick with chronic disease. We are sitting on lots and lots of patient data that is untapped with the right appropriate consent, like what Maneesh was describing. There's a huge opportunity for us to do better, but it needs precise regulatory oversight. Let me pause there and get reaction.
Yeah, thanks a lot, Anil. This was really interesting, and I'm sure we're going to come back to many of the points that you brought up, but let's first move on to Soroush.
Thank you, Dan, and other panelists. So the question that I was asked was that given your collaboration with institutions like Mayo Clinic, and I would add, I've been collaborating with many other hospitals, MGH, as I mentioned, Beth Israel, Dana-Farber, both nationally and internationally. And the question says the state health departments. So I've been working with governments, both the US and international governments, trying to figure out some of these issues. The question says, what are the most pressing challenges you've observed in translating AI innovation like LLMs from academic research into scalable and real-world healthcare applications? Well, the challenges are obviously a lot, and the other panelists mentioned some of them. I would like to divide them to two categories. One category is the things that have received less attention, and the second category, things that have received, I think, enough attention. Both categories need a lot of work, but in terms of the first category, I can summarize based on a lot of experiments that we've done with Mayo Clinic, MGH, Dana-Farber, etc. I can summarize three main issues that we have observed in our experiments. And so, one of the issues is what we call algorithm aversion. This is, the fact that for some reason, medical experts specifically don't like to, for some reason, to rely on algorithms. And so this is one of the issues that I think, needs to be, hopefully with training and better development of algorithms, this is changing over time, but still we are not there. And so there is, good level of algorithm aversion that our research and other researchers have, established. The second one is human aversion. So the second one is more about algorithms not being, correct or reliable in a lot of cases. This is the fact that, algorithms in critical decision making. This is not about decision making in terms of, documentation or summarizing patient data or things like that. But when it comes to critical decision making and coming up with treatment recommendations that are complex for patients, I think a lot of algorithms have what I call human aversion, is that they provide recommendations that don't match, human experts' mind. And so therefore, having physicians follow that in their practice is a big ask to me. And the third issue that we have observed, and we have provided evidence on this, is what I call causation aversion. So, Maneesh mentioned a lot of algorithms that are at the predictive level. And so most of these algorithms are at the predictive level, which can work for specific applications. But in a lot of applications, and if you think about what clinical decision makers, doctors, and etc. need in a lot of cases, they need help with understanding the causation. What if I give this, treatment instead of this other treatment? And I think, we haven't developed algorithms. And if you think about transformers, the LLMs, essentially, they are all at the predictive level. So they're good for, making predictions. They essentially predict the next token, right? They're good. They work well in a lot of applications, like, again, summarizing documents, or, for providing recommendation for prior authorization, for instance, right? In those applications, they work. But when we come to, applications like treatment recommendation, that's we are trying right now, working with Dana-Farber, Amazon, and Harvard Data Science Initiative on a large project, trying to develop AI tools that can, provide personalized treatment recommendations using detailed genomic data for each cancer patient. Those applications, these LLMs are essentially not useful, because they are developed based on principles of association, which is not what you need for providing, treatment recommendations. So I think, to me, causation aversion is another thing that we need for decision making and for providing treatment recommendations. And then there are other issues that are relatively more well established, and other panelists also mentioned things like access to the data. So for training these algorithms, you need a lot of data, and because of HIPAA and other regulations, I know, Maneesh, you mentioned Mayo Clinic. I know they've been working on this, of trying to provide large scale data, but still we are not there. And I hope you guys agree that there is a lot of work that needs to be done to provide the amount of the data that is required to train these algorithms at a successful level, not at the level that that you can write a paper with, at the level that you can implement in practice and use it reliably at the practice. There are, of course, clinical validation issues. We haven't still figured out how to validate these tools, in a reliable way. To me, we need clear regulations in terms of clinical trials for algorithms. We do clinical trials for drugs. We don't do clinical trials that much for AI tools. And so I believe we need to move towards that. Another issue is about, in terms of integrating these tools with the workflow of the hospitals and workflow of the physicians. A lot of these AI tools, especially in academic settings, this is the question I'm asked, they are developed, without thinking of, clinical implementation. And so when it comes to clinical implementation, we need to make sure that it matches the workflow. Lots of things have to happen so that they can be implemented actually in the practice. I mentioned about regulatory challenges, the fact that still FDA doesn't know what to do with AI tools. Essentially, I'm not exaggerating that much, and there is fear of litigation, and this is similar to me to using self-driving cars, of the insurance companies not knowing what to do. In medicine, it's not that different. We haven't figured out what happens when we implement this AI tools, and what happens, anything has a mistake, right? There should be a safety sort of guard for this AI tools as well. We know if a physician makes a mistake, there's a process for it. We don't know if AI makes a mistake, what the process would be. And then lastly, I want to mention about sort of, transparency and explainability. And a lot of those are based on the fact that we need, this AI tools to, be able to explain themselves. But that is different to me than, I think we have done a lot of work, and by we, I mean, the entire human being has done a lot of work on making this AI tools, explainable. But this idea of, if you explain something to me that still doesn't match my intuition, I'm not going to follow it if I'm, worried about lawsuits and a lot of other things, right? So explainability is different from what I mentioned about causation aversion, and the fact that, a lot of these algorithms do not match human intuition of the best experts that we have.
Yeah, thanks a lot, Soroush. I mean, hopefully we'll come back to some of these important points. But first, let's move to Gagan, our last speaker.
Yeah. So the question I was asked was, with your expertise in human AI interaction and agentic systems, how should we design LLM-powered agents in healthcare to effectively collaborate with clinicians, supporting their decisions without overwhelming or misleading them? I think there are several keywords in this question that stick out to me. The first is LLM-powered agents. The second is effective collaboration. And then there are these requirements, like not misleading the physicians or the healthcare providers or not overwhelming them. I think let's first talk about the word LLM-powered agents. We've gone from chatbots to agents. And what is the key difference there? One of the key differences there is, think of personal assistants that can not just talk with you, give advice to you, but they can actually handle the task for you. So now if you think of healthcare applications, like for instance, think about a medical research assistant, or think about a medical patient care admin, that's an LLM agent, or think about a tumor board expert that's based on agents. When I think of agents in these healthcare domains, I'm thinking about really the ability to act and not just chat with the physicians, right? So that's one of the distinguishing features. The second big keyword in this question was effective collaboration, or effectively collaborate. I think the word collaborate is very complex. It can mean a lot of things. I think we can all disagree on what that could mean. But I think the phrase effectively collaborate, that's kind of a little bit easier to get on the same page about. We can all kind of have a sense of when a collaboration was effective or not. When I think of of the term effective collaboration between people and AI, the term I immediately go to is this notion of complementary performance. Like the real sort of decision theoretic rational check is, was it worth using it? Is the team together as a whole working better than either alone? If that's not the case, the rational argument is to get rid of one of those. So putting these two together, LLM-powered agents and effective collaboration, I think there are just so many challenges there. They're challenging as the NLP and the machine learning side of creating better reasoning models. There are all these challenges, at the side of systems issues and privacy issues and policies. But on the side of improving the interaction between people and these agents and all these, at least 3 domains that I listed in healthcare, I think there's several themes that pop up. And there's what I'm going to refer to as this recent paper that we published on challenges in human-agent interaction. It's sort of a broad overview of the various challenges that we think occur in that space. And one of the big challenges there is understanding what can the agent do? What is its action space? So for instance, think about, an agent that you make that can write arbitrary Python code and can execute it. What is its action space? It can do a lot of things. There's a number of ways it can impact its environment is many. And so now you go back and go to, these healthcare applications, maybe a medical research assistant or a patient care admin. What is the action space of this agent? In the case of a medical research assistant, can it go and access all the papers via an API? Can it go plot a visualization? Can it go write the first draft of the paper? And similarly, if you go to patient care, what is this action space? Does it have the agency to actually go reach out to a patient? Or can it just only chat with the doctor? Can it go and order medicines at the local pharmacy for that patient? Are you going to allow that? And the reason this understanding this, what can the agent do is so important is because actions have consequences. In fact, some actions can be irreversible. So I'm going to tell you a story about a recent paper that we published, and there was an interesting log that we saw. So this was a very popular data set from Meta. And one of the tasks in this data set was to go to FDIC's failed bank list and figure out what was the total dividend that a bank paid to another bank. A really complex question we may not ask. At some point, one of these agents could not figure out the answer. And so what it did was instead, it started to create a FOIA request. And that FOIA request was very, very interesting. So it's filing a Freedom of Information request and it says, under this particular act, I would like to demand this information. And in the email, it composed, if there are any fees associated with these records, please inform me before you fulfill the request. However, I would like to request a waiver of these fees in that the disclosure requested information is in public interest. Further goes into legalese and say, if my request is denied, I need this justification. So left unattended, these agents powered by these new models have the agency to do things that you may not want. So I think to create effective collaborators in these medical domains, at least these LLM power agents, we need to really carefully think about their action spaces, have guardrails in place, especially when they're irreversible actions or possibilities of them. And now that's an open-ended question. There are other problems, for instance, common ground. The notion of common ground is something that's borrowed from literature in human-human communication. If you look at how people collaborate, they really need shared understanding of what the goal is and the process to achieve is when they do it. Like think of, two pianists playing four hands. They need to know what the piece is before they play, and while they're playing it, they need to coordinate them too. And so in all these applications that I talked about, physicians or healthcare professionals might want to know, what should the agent achieve? Is there a shared understanding between the agent and the physician about what it should achieve, especially when the goals are complex? Which preferences should be respected? And the agent, in turn, might need to know about what has been communicated in the past. And this is a very rich space of challenges that I can talk more about later. And finally, I think I want to come back to something a lot of panelists talked about here, which was explanations. I think the reason we wanted explanations in the case of these predictive models, because they're inscrutable. We can't figure out why they recommended a particular decision. If they're asking you to take out your kidney and they said, well, I was 99% accurate in the past, you still want to know why. And in the case of agents, this has become even more complex because they're not just giving you a single prediction, they're giving you a trace of reasonings and actions. And how the heck do you make sense that why did it do this particular action? Why, if we gave it the agency to, you know, go do a literature survey on a particular topic and prepare, let's say, an expert advice on the effect of drug A on a particular condition, why did it recommend that? And you know, this is an open problem because we know from a lot of literature and explainable AI that that notion of complementary performance I was talking about before is very hard to achieve. If you look at the ratio of papers that talk about complementary performance from explanations versus the number of papers on explainable AI, that ratio is really poor. So with agents, I think that's another big. So in summary, I think the three things I would focus on, or good starting points, are think about what can the agents do, or their action space, creating shared understandings between people and agents, and then really trying to think about what is the right level of detail so people can appropriately rely on these agents.
Yeah, thanks a lot, Gagan. So this was really interesting. I mean, all the presentations, we don't have a lot of time, but I want to start the rest of the discussion with one comment and a question, one of the many questions I have. So I want to start with this thread that almost all of us have mentioned that have to do with evaluation, explainability. So you know, one of the first things that I've done when I joined Oracle was kind of developing the framework for evaluation. And evaluation is really crucial for what we are doing, not only as a way for us as computer scientists see how well we are doing or how well the models or the services are doing. It's mostly important to the users, to the customers. And this brings up the key component in evaluation, which is observability. We need to be able to show what models are doing and why. Explanation is part of observability, in my view. But one issue that is important to realize is that just like models hallucinate, models provide explanation that are often inconsistent with the final answer. And this has been documented a lot. So this is one risky area for us. We cannot, I mean, we need to work on this, of course, but we cannot just rely on explanation because often these are inconsistent or conflicting with the final answer. And to me, in the healthcare domain, this issue of conflicting information, either between what the model is saying at the beginning to what it says at the end, or even in the data. I mean, if you look at clinical trials information, you know, over a period of time, you're going to see conflicting information there. How do we deal with this information, both on an algorithmic technical level and also on a process level? So to me, that's a challenge for this. And I want to stop here and ask another question, and then you will choose what you want to address. So the other question I have is, there are many healthcare problems, and I'm interested in your view, especially kind of the medical experts on the panel, on where do you think the first penetration is going to be? And you know, maybe we can divide it partly to kind of two big classes. One of them is kind of on the diagnostic aspect, and the second one is maybe on the management, you know, billing or prior approval aspects. In all these cases, there are a lot of risks. Where do you think we can see the first acceptance or penetration of this technology? And just volunteer. I see Anil wants to respond, so please.
Sure. Yeah. I mean, I think it's near and dear to us for sure. I think you kind of alluded to what drives the second question in the first question. I think we have to go through a series of maturations and trust building with the clinical community. So the first area that there's great promise for is on the administrative side. You alluded to prior authorization. These are heavily data-centric types of use cases, summarizing the medical record, for example, listening to a conversation and helping the doctor or the nurse document the encounter with something else that you said earlier, Dan, on your first question. You said the final answer, where sometimes the explainability doesn't support the final answer. Well, the final answer in many of these use cases is the human in the loop. The physician is the only one who's able to make that final determination. He or she is going to have to weigh the evidence for and against, because medicine is not perfect. And you kind of alluded to the literature. And so I think the biggest problem right now in healthcare, even on the diagnostic side, is it's very data rich and information poor, and even worse on the insight side. So I would say the use cases that are getting a lot of traction and are in use today are on the summarization side, are on the administrative burden of bringing together disparate things. And if you kind of fold that into what Gagan was saying earlier around agents, there are lots of use cases in which we are asking people, highly trained people, to operate way lower than their licensure, asking physicians to go do things that an agent can do by summarizing the medical record, or asking a nurse to sit on hold for 40 minutes to help a patient schedule a visit, in which a scheduling agent can go do for the patient. So I think, to answer your question very crisply, I would focus on the administrative operational challenges that drives nurses and physicians and other healthcare professionals crazy because they're not able to operate at the top of their license. Now, there are some interesting diagnostic ones. I mean, none of us would go to a radiologist in the US today who claims not to be using any AI in their field. We'd run away and go find somebody else. So there is, on the diagnostic side, significant progress. But just like I don't use an EKG machine to diagnose a urinary tract infection, we got to make sure that the doctors are educated about what tooling are they using for the right kinds of things. And so explainability is only one element of it. The second is, what is our responsibility in making sure we do the implementation and the training and the education. And then most importantly, during medical school, I learned how to use a stethoscope. I learned the importance of an MRI machine and an EKG machine. Where are the next generation of clinicians learning? When is an LLM appropriate and when is it not? And so I think there's a long answer to your question, Dan, but I think it's more complicated. But we're moving quickly, so we need to be focused on the back office administrative, but the diagnostic stuff is catching up very quickly.
Yeah, I can also echo some of the points that Anil mentioned. And in fact, I think like one of the main areas that these tools can be really helpful is to make sure that physicians can spend more time with their patients. Right now, they're spending a lot of time with documentation and with things that could be automatically given to an LLM in terms of documentation or conversations with the patient. You can write it to give it to the LLM to have the conversation maybe with the patient, and have the physician actually spend more time with the patient on things that can really be helpful in terms of improving the quality of care that they deliver. I think in terms of diagnostic, there's been a lot of work as well, as all of us know, and they have been a lot successful. But I think if we think about the future of using AI in healthcare, I do believe that treatment recommendations is where we need a lot of attention and a lot of work. And I think going back to the other question that you asked, to me, we need to have, clinical trials. There have been a lot of arguments at the Congress and elsewhere about giving, creating these entities, organizations, could be academic labs or other entities that can, rigorously do clinical trials, but with AI tools, and that can, increase the trust of the physicians. Right now, as I mentioned, their trust in AI tools when it comes to critical decision making, treatment recommendations that are very, very complex, not, easy things like, okay, this patient has flu symptoms, things that are really complex. I think that can increase the trust of the clinicians if it has gone through very rigorous trials and tests and experiments. And that's why they do already in terms of, using the drugs. They go with drug A versus drug B because latest clinical trials showed that, drug A is much more effective. And so if there is evidence in terms of, clinical trials with AI tools, that can also increase their, trust in AI tools, and then they can use it more often.
Yeah, thanks. And any other comment or questions on this or other topics?
I
I have
just
one.
close. Oh, go ahead.
No, Duncan, please go ahead.
So to you both, because you raised some very interesting points, I would just ask, you both know how to use previous tools to evaluate the correctness of models, that you would look at an output to use an EKG to treat a UTI as something crazy. But in a world where physicians are overburdened already with many, many answers, how does that affect training the next generation of physicians that may begin to just sort of trust the output of responses that are generally 99.9% of the time correct? And how does that affect the learning process, would you say?
Yeah, I think it's, I'll be very brief on this. I think it's a really important question. There are some medical schools that are now allowing students to use OpenAI and other forms of LLMs to do their work. I think it's the new norm. I think recognizing when the answers might deviate from, and I would say in healthcare, nothing is black and white, as you might imagine. So 99.5% may not mean a whole lot. Sometimes when I started training, it was do whatever the gray-haired gentleman down the hall tells you to do. And then there was a generation of population-level evidence-based medicine. And now we're kind of saying, okay, but now with LLMs and with all this rich data, maybe we can start to go to a more personalized medicine approach. And so I think students of the future, medical students of the future, are not going to be carrying large textbooks around looking for an answer from them. They're going to be querying a large language model, and they're going to need our help in order to understand where are the guardrails for them to do this. But I also think the level of hallucinations that is being tempered by knowledge bases and by other forms of essentially boosting the accuracy of some of these things. But I will tell you, the most critical thing we look for in medical students is reasoning. And we're not replacing that anytime soon. So as long as our students focus on clinical reasoning, I think we're okay.
But are you concerned that the use of this tool will impact the level of critical thinking that these people develop?
Possibly, but look where critical thinking has gotten us. Physician intuition has led to medical error after medical error after medical error. Until we started working with checklists, and we started working with guidelines, and we started working with evidence-based medicine. Until then, we thought that our intuition was so good. But sometimes, as I point out to some of my students, the janitor cleaning an ICU has a better handle on which are the sickest patients based on the number of IV pulls than the doctors had. And so we have to be careful about trusting intuition over knowledge. And I think as you all, who are the engineers in the room, get better at building these things, I think we will start to have a generation of where information is more available and the students can do clinical reasoning. But you're right, we have to be careful. Now that I use GPS everywhere I go, I no longer know exactly how to get to places, but I do know that GPS is going to give me a better result than if I try to use my brain. So I think we have a long way to go to figure that out, Dan. But the good news is there are some medical students who are now thinking about this, who are now bringing this up. And I think we have an opportunity to engage with the medical schools, the postgraduate training, and get them involved in how we're building the curricula of these organizations.
Do you have a prediction
but
about?
I would say that I think there's no. Well, one comment, Gagan. There's no contradiction between critical thinking and developing skills for critical thinking and checklists. I mean, my concern is that sometimes relying or over-relying on models will prevent people from thinking about what are the right questions, even if I want to pose them to a model. So really the educational process has to think about these things critically. Anyhow, let's move to Gagan. You wanted to comment.
Yeah, I just had a small question for Anil again about if you've seen any like evidence in real world thus far. I know the world's looking optimistic in this sense of like cases where diagnosis was made using these systems, and we're seeing hospitals or healthcare providers that are adopting these technology that are giving out. So like we've seen these results with GitHub Copilot, programmers using that are twice as fast or all these kinds of. Where is that?
These
I
are,
guess,
by the way,
result.
rumors. I don't know that this is true and has been shown. So that's I think we are all falling into the trap of assuming that what's written in social media is correct. There's no proof, perhaps anecdotal, that people are becoming a lot more productive using programming tools, for example. We don't know how much time people spend reversing wrong decisions that programming tools make. And so we have to take everything here with a grain of salt, and definitely in the healthcare consulting domain.
Sure.
Yeah,
I think for the programming case, there's definitely been randomized controlled trials where we've seen control group A is faster than the control group B on the same problem. But of course, the studies have their limitations. I think adoption at scale is a good number in this case, but totally agree that we should be very careful, especially of anecdotal claims on social media.
Yeah, I'll give you one quick example. What we see is that ambient documentation, for example, makes us way more productive. I mean, these are some very large meta-analyses, makes us more productive, but at what cost? So the notes that get written by the ambient, when we are not going back and annotating those notes in the same way we would if we wrote those notes de novo, don't have the same level of detail. And for those organizations that rely on the level of detail in order to do optimal billing, it has caused some issues with them. So I think we do need to look for, does my improvement in productivity impact another member of the health ecosystem's inability to have that level of optimization? We don't know the answer to all of that. But look, I'm an optimist. I was a biomedical engineer in my background, and now we're building tools. So I have to believe that if we build it right, there is going to be a positive impact, but it's not going to happen in a vacuum. There has to be sort of an evaluation model that looks for all the parts and pieces of a health ecosystem and make sure, unlike EMRs, electronic medical records had a very adverse impact on the quality of life for clinicians, right? We got to look through all the parts and pieces and make sure there are no unintended consequences through that process.
Soroush, you're muted.
Yeah, I didn't have much to add. I think Anil pointed to the main reasons, and I do think that it depends on how we evaluate productivity. To me, at the end, it's about quality of care that is delivered to the patient. I'm not, thinking about billing or other aspects of productivity. I think if we think about the quality of care that is delivered to the patient, is that going to be better with AI or without AI? To me, that's the most important question. And I do think that the answer will be yes after some work. So you mentioned, about medical students being trained. To me, the AI is also a student right now that, needs to be matured. And once it's matured, then we can see, hopefully, that we can provide evidence, rigorous evidence that, that it can improve the quality of care that is, delivered to the patient.
Yeah, I think this is a good time to finish this panel with this optimistic view. I want to thank you all for participating. Thanks for the audience that we don't see, but hopefully is there. And yeah, hopefully there's a lot of stuff that we left for people to think about and us to think about. Thanks again.
Well, thank you.
Thank you.
Thank you all. Thank you, Dan.